All right, good afternoon, everybody. We're going to go ahead and get started. Thank you for joining. Let's see, everyone should have received the minutes that were sent to you after our last meeting. And so we do need to have a vote and approval of those minutes. Can we get a motion to approve the minutes, please? If you approve.
DeBurkett, motion to approve.
Okay, thank you.
Hey, second, Marty Wynn.
Great. Thanks, Marty. I appreciate it. Thanks, Dee. All right. Thank you for that. I'm going to hand it over to Liz for some GTC updates. Then we're going to do some work group updates, at least one. And then we'll talk about one new business or two new businesses, and then we'll be finished. So Liz, I hand it over to you.
Thanks, Michelle, and good morning, everyone. Good afternoon. Thanks for joining us. Lots to update you with the commission. I'll try to be brief, and we'll include these in the minutes so you have dates and all of those important details will always be posted to our website for meetings. But three big initiatives that we have coming down the pike. One actually just passed us a couple of weeks ago. The level 4 trauma centers had their consultative visits with the Pennsylvania Trauma Systems Foundation, and we got great feedback on that. The level 3, level 4 committee just met on Friday, and we are trying to get as many level 3, level 4 folks or level 4 folks to the November 17th commission meeting, because the Pennsylvania group is sending their board chairman, who was actually one of the surveyors who deployed. There were 2 survey teams that were deployed to Georgia to do the consultatives for the level 4s. And he, along with 2 of the other site surveyors, will be discussing the aggregate strengths, opportunities, and recommendations for the level 4s. And so this is because many of you who are in the midst of your ACS process for your level 1, 2, or 3, ACS consult or verification. ACS does not have a process for level 4 consultation or verification. So we brought in the outside entity. We sought 2 entities that actually have fairly mature systems and really a long-standing history of good data collection and good oversight of the level 4 centers. So in this instance, it was Pennsylvania. And we're really excited. We've allotted 90 minutes for that group. They have about an hour presentation, and they want to have some dialogue on what the next steps forward are. So we're really excited to hear about that. November is actually morphing into, it's always been the commission's annual meeting, but it's morphing into our rural focused meeting, because the 3rd Thursday in November coincides with National Rural Health Day. So it's a great time to focus on all of our rural initiatives. The Georgia Rural Health Innovation Center will be there, and they'll talk about one of the programs that they are linking up with us to provide support, and that's our March Pause program, which you may have heard about, which is that March Pause is just an acronym for a sort of rapid assessment and treatment of life-threatening injuries that we're taking to the rural area. And our very own Emmanuel Medical Center has been involved in that. Thank you, Damien, if you're on the call. They've handled the grant with that. And also lots of movement on that. There's a pilot course about to happen first week in November. And the first pilot course is going to be at Emmanuel. So finally getting that across the finish line. It's been a long time coming, a lot of planning and preparation. So after our November 17th meeting, the next big thing on the agenda will be, and many of you have this as a meeting invite, and I promise we're going to update that so it doesn't take up a whole week on your calendar, is the American College of Surgeons Trauma Systems consultation. For some of you who've been in the system for quite some time, you may recall that back in 2009, we had a full system consultation, and we were going to have a rural focused consultative visit, but in our many discussions with the ACS, They felt like they really needed to know a little bit more about the entire system in order to understand the context with which rural operates within. So this evolved from what was supposed to be rural focus to a full systems assessment with a rural focus. So it's essentially 3 days on site with the stakeholders. So the team will do a pre-recorded sort of welcome message, if you will, that will include an overview of what the process looks like and what we should expect. In addition, Dr. Ashley, myself, and Renee Morgan will do a presentation on what has happened in Georgia in the decades since our previous visit. And then Monday, January 9th, will be the full systems assessment. That will be at Lake Blackshear in Cordele, Georgia. And then following that on Tuesday will be a half-day South Georgia rural focused visit in Cordele, same location, Lake Blackshear, from 8 to 12 in the morning. And then on Wednesday, we move up north to Cartersville to cover the North Georgia rural focused consultative visit. So we're asking if you're in sort of those northern tiers that you have your presence at the Cartersville location, and if you're in that EMS region 5 through 9 area, that you be at day 2 at Cartersville. Day 1, we want as many people to join as possible. We know that it's problematic from a travel perspective, so we do plan to have sort of a high fidelity web-based experience, if you will. So also we're a little bit capped on the number of people we can cram into that venue. So we do have a stakeholder list that the ACS wants to have there. So many of you are on that list and we've already reached out to you. So thank you for that. And we will continue to post more details about that and send specific invites if you are on that stakeholder list to be involved with that. And I think, last month, Dr. Ashley would hang me for not saying this. Last month, Dr. Ashley presented finally the level 3, level 4 readiness cost survey at the American Association for the Surgery of Trauma. That was really well received. You know, I've said this many times, we're the only ones with data, cost data for level 3 and level 4 trauma centers. The level 3 shook out to be about 1.7 million. And the level 4s were just over 80,000. I will say for the level 4s, if you're out there and you're hearing that 80,000 number and that sounds so low, it probably is a little bit low. Once you hear the results of what our colleagues in Pennsylvania found, I think that once we get up to snuff that number, if we reevaluate this again, and additionally, when we reevaluate the level 3s after everybody is ACS verified, we do expect that the costs will go up. And for those of you, if you don't have a frame of reference, the level 1s and 2s, the level 1s were roughly about $10 million, and the level 2s were approximately half that, around $5 million. And again, we have all the manuscripts on those. We probably need to put those on our website so people can easily access those. And I'll pause there, Michelle. That's a lot of information, but happy to answer any questions on any of that.
All right, thanks, Liz. Appreciate the updates. Lots of great work happening, that's for sure. I love that we're leading the country in a number of ways, particularly with the work that's happening in the rural counties. So that's great news. So next on the list is our work group updates for finance. And Regina, I'll let you speak up as well if you have any updates on this. I know from my perspective, we still need a chair from one of the level 1 centers. And so I think that is something I have an opportunity. We have someone who may be able to fill that. We just had some competing priorities step up in the last month or so that have caused some challenges with that. Regina, I don't know if you have any updates on that. I know you all were doing a little bit of work in Augusta. All right, well, we'll move on. Francis, Amy, do you want to update on the diversion work group and our last meeting and what's being accomplished there?
Sure. Can you hear me okay?
Yes, ma'am, we sure can.
So really high level, and Amy, jump in, correct me where I'm wrong. The group has met twice, really with the intent of establishing our, really our purpose of the group, which we have isolated specifically to trauma transfer diversion, really to work on that in isolation. We really went around and shared best practices, which there's a lot of really great best practices around the state that we would really like to publish in some way, shape, or form. I just need to draft those as suggestions, kind of stamped and blessed by the state of things that we can do, particularly during spikes. And then lastly, in the last meeting, we looked at the new, and Michelle, you'll have to give some more details on this, the new regional coordinating centers option to have a trauma transfer diversion status open, which the request from our group was that if we have that we make it actionable if, more than 50% or so of the trauma centers go on diversion, that something is done to communicate when those will be coming off diversion or working together to get some of those off diversion. So that's really our group's update. Amy or anybody from that group have anything to add?
Summarize it quite well.
Great, thank you. So I think the request is, and the team, I believe, was going to take it back to their trauma medical director group, but we have a request. It's actually the GTC request. Myself and Regina and Dr. Ashley and Dr. Dunn and a few others to be able to create in the Georgia Coordinating Center, which is a statewide website that is mainly used actively every day in the Metro Atlanta, but has the ability to be used throughout the state. We also did use it throughout the state during COVID, so many of y'all are probably familiar, and many of you actually do update it because we can see the updates in the system. But the request to create a trauma transfer diversion to be able to communicate only with the trauma centers and other centers that would need to be transferring a patient to you. So the why behind this and why this came up, actually Amy was impacted, many hospitals were impacted, but that's the story I always remember the most, was in the height of COVID, trying to transfer a trauma patient and everybody was on diversion. When in reality is if we have an effective communication plan that we could most likely regionalize it. You wouldn't want to do it for the full state unless we had a true statewide MCI, hurricane, or something like that, or COVID wave. But within a region, be able to communicate the status of trauma centers and what they are able to take. Total diversion, trauma transfer diversion, so that within that region, if you are a smaller hospital that transfers, or if you're a hospital that's not a trauma center that still transfers regularly to a trauma center, that you would know who is available. Within that, we would ask the trauma centers within those regions to develop a plan around not everybody being on trauma centered or trauma transfer or trauma center diversion. And I think that's, I know that is already happening in certain regions, and there's already communication, but we really need to solidify that and communicate it so that everybody is aware of what that process is. So there was a request that change is able to go live. It's been available in the GCC, but what we would do prior to that is we would develop an education plan and roll out. It wouldn't roll out tomorrow. You all would be involved in that process as well. So that was the request. And Francis, Francis or Amy, was there any feedback that you all received from the other subcommittee members, work group members, about why if we shouldn't do that? I didn't get that feedback, so I'm just verifying before I pull the trigger.
No, we did not get any negative.
Okay, great. Does anybody have any questions about what that would look like, or about what that process would be? And I can pull up, if you would like, I'm pulling it up right now. I can pull up what this would look like for you. Matter of fact, I will do that just so everyone has it. And I got to figure out how to share from, thank you. From, all right. How do we share from, I've never shared from Zoom. Oh, there it is right there. I knew there was a button. All right. Can you all see the screenshot?
Yeah, we can see it.
Okay. So this is Regina Augusta. I was the proxy for this. And so this is the GCC website. It is a public domain. It is open to public, but this piece could be behind the scenes. Every single institution in Georgia has somebody that's been assigned to update this. You may or may not know who that is. We can find that out for you. And the why behind that, or the reason, is during COVID, the GCC was the transfer center for COVID. And so every hospital was using it for a period of time. Not everybody was doing it consistently, but you could go in there and there's multiple diversion statuses that you could see. It's in 2-hour increments. It can go all the way up to 24. And so this bottom one is trauma transfer diversion. So if Augusta or Memorial or Grady or somebody is on trauma transfer diversion, we could put that there. This other centers can see that, and it helps facilitate early communication and no delays. We would also then ask, obviously, within the region to create a communication plan around that. So that is what that piece looks like. This is what it would look like if you were the hospital. So this is what is open and the community can actually see. And you could, we got to remove that little blurb. I'm not sure why, but it says trauma unable to accept transfers. And that is what would be communicated so that people could see that the trauma center would not be able to accept transfers. Any questions?
So Michelle, that's just that piece that we wanted added about you're open to ER traffic, but you're not able to take so they shouldn't even bother calling you essentially.
Correct.
Right?
Correct.
Okay.
Correct.
Can you hit this is just from an email. It's not the live site again. I was going to ask if you could hit the drop down. I was just curious of what other, is it just the regular other types of?
It is. So it's
events?
STEMI.
Okay.
There's, the STEMI, total, medical, ED. There was a request. So there was 2 meetings. There was a meeting in Metro Atlanta related to the AMC closure and GCC. So that meeting happened about 3 weeks ago. There was also a conversation about having Francis and Amy lead a team, and maybe we've joined these somehow or use GHA to facilitate definitions so that everybody is consistent and the definition is the same to everybody. And that how do we create that regional plan at the same time, ensuring that we're all using the same definitions. Right now, NEDOCS has been the scoring mechanism. Not everybody's using that, but that is what's built into the GCC. So that was, we need to do some work around definitions, because right now I think there's a lot of variability as to who's calling what. And so that's definitely one of those early things that would need to happen, but we could move forward with this because it's pretty self-explanatory for the trauma center diversion or transfer diversion.
Hey, Michelle, this is Becky Weidler from Northside. Did you announce a timeline for this? Because I agree, it's pretty straightforward trauma transfer, but do we have a timeline in mind?
No, not yet. We wanted to bring it to this group. It will happen. It can happen pretty quickly. If you all have a preference, we could, I probably wouldn't do November 1st because we want to educate, make sure everyone's educated, make sure everyone has access. So maybe like a December 1st, something that gives us a little bit of leeway to ensure all the centers are using it, they understand how to use it, and they have the right people to be able to do it. And that'll be right before we all hopefully don't have our winter surge, but most likely we'll have our winter surge related to that. So, there's not a deadline or a timeline. We could easily set one.
Okay, thanks.
Any other questions?
I was going to ask you if, or any of the adult centers on here, if with the RSV problem being so widely publicized, I didn't know if that was handling some of sort of the age limits. I don't know how full CHOA is getting. I was just curious if that's been an issue.
I don't know if anybody from.
Yeah.
Looking to see.
This is Becky from Northside. We've certainly seen some significant delays in them accepting, those types of patients to the point where we've kept just a few in our ED for 12 to 14 hours. I did reach out to the transfer coordinator there, and they were just really struggling with the volume. They actually asked us, based on where we live, where we are, if when they're in these crises, that we look out to Greenville, to transfer to Greenville, which finding an accepting facility is one thing. Finding an appropriate level of transport is, as we all know, the second layer of issues there. So in the last 2 or 3 weeks, have not heard much, but do know that we are feeling a little bit more influx from their urgent cares coming straight here to our ED before going downtown.
We've sent multiple children to Birmingham or Erlanger because everyone in the state is full. But Stacy, I thought Stacy was on. I thought I hadn't seen her. Let's say she just wrote. Yeah, I know that they're very, very busy. I know Stacy mentioned that on our our work group. Extremely high volume. But Stacy, if there's anything else you want to update with the team, sounds like lots of folks are having speaker issues today. You can just put it in chat for us for that. But that has definitely been a challenge. Well, I would like to propose that we, and this is not something we have to vote on, I don't believe, but if we want to go forward with like a 12-1 go live, what this would mean for this group is that we would not most likely, we would have an opportunity for you and your whoever from your institution that would be responsible for this, getting an overview of the system, making sure everybody has sign-ons. That would be with Lori Wood, who's our executive director at Grady. This is at Grady, but is actually funded through the state. This process is. And then from that, we would do education to make sure everyone knew exactly what it was and what it meant, and then be able to pull the trigger. So it gives us a little over a month, about 5.5 weeks, to be able to do that. Does that sound reasonable, or does anybody have any disagreement with that? All right, well, let's jump back to Regina. Did you get your speaker working? Maybe, maybe not.
She did post in the chat, Michelle, that that they continued the work that Katrina started, and they established a finance PI committee and have met twice since the last admin call. And they're working on I think it's a facility specific finance dashboard to share with the group. I don't know if Regina's able to.
Yeah, she mentioned the dashboard when we met last, that they were working on one that you would be able to be replicated at other institutions, so institution specific. So that is great, and still not working. All right, Regina.
You're still, I'm showing you muted as Regina. Do you want to try it again, or?
All right, so let's move forward. Damien, do you have any updates for the education work group? I know he was here. I thought he was, maybe not. All right, well, that is our regular agenda items. Does anybody have anything that they want to share? We have a couple new business pieces, but well, let's go ahead and cover those and then we'll ask for new items. But we want to just bring up the AMC closure discussion to ask if anybody had any questions. I will tell you, being in the only other level 1 in downtown Atlanta, we've obviously been in crisis mode planning since that happened. The announcement was made. We have seen a very significant increase in trauma volume. both by ground and air, as well as some transfers. But we're maintaining, we're able to function. We did open up a 29-bed unit that was already pending opening that we were able to get open. And then we're still working with the state to get the 24-bed temporary medical unit that was, I think we're getting the one from Macon to come up here as well. So that's hopefully by the end of the year. I'm sure you all saw we did get additional funding for new beds. That will not happen in the next year. Most likely early fall will be our first opening of some of those beds, and they obviously won't be happening all at the same time. So I don't just entertain any questions or anything that anybody wanted to ask or share. I can answer or pass on or have others answer as well. I will share that we will no longer be going on trauma diversion or total diversion. We made an executive decision. We were doing that, obviously, like everyone else, many other people were before, and we've not done that in the last month. So yeah, Stacy, it's anywhere from 20 to 30% a day increased volume that we're seeing. So it's really, we're able to look. I mean, we obviously, Wellstar was very, very accommodating and sharing data and helping us with that. So we were able to know what to expect. And we had great collaboration with our physicians already. And so we kind of knew a little bit of what to expect, and we've seen it. It's been exactly what we would have expected to see.
And Michelle, I don't know if you saw well, first I saw Stacy did post that they've hit 1,000 on Sundays for all EDs, and have had to transfer out of other PICUs or decline at other times. And they're exploring ways for higher acuity patients on floors to alleviate the PICU volume. And so it's a work in progress. And then Francis posted, would strongly suggest a communication of the trauma transfer diversion launch. We couple that with best practices used throughout the state during spikes. It would feel like a miss if we didn't use that opportunity to educate about the possibilities for patient movement. And I will say, maybe this is something to bring forward to the TMD group, because one of the things that we saw during COVID was, there were a lot of transfer of patients, and this is where maybe potentially, and for those of you who have it, telemedicine could be helpful, because some of the patients that we saw taking up the resources of the trauma bed were, elderly patients who, when they got to that destination, their care was decelerated anyway due to goals of care being discussed. So, if we're not going to do anything anyway for those patients, and when you look at it from a system perspective, that can actually be a decent amount of patients. So, so to be able to have something, particularly as your volume continues to increase, Dr. Ashley and I have been talking in some of the comments we've been asked to make, is that this is Atlanta Medical Center closing is not an Atlanta centric thing. I mean, you get patients from all over, and when we did an initial map of some of where the Atlanta Medical Center patients were coming from, it's all over the state. So, in theory, there could be a backlog. In addition, people at the trauma centers around the state transfer patients to you. So as your volume goes up from the local volume, we still don't really have a way to manage what was already a very stressed system that COVID only magnified. And so I would assume this would be another sort of COVID type situation.
Yeah, I believe so. I mean, so we've been because we do have the data, we know what centers we're transferring. There's been some outreach and communication with particularly the ones that did a lot, not so much the ones and twos, but the larger volume centers that transferred in. There's already been ongoing communication at the executive level about what that would look like. But that's why this is so important for us to have it start that statewide, at least communication, so that when we are transferring or if someone's having to transfer, they know what's available. And then again, the next step is regionalizing. What does best practice communication look like in each of the regions, so that you have the ability to see what is going on and you don't have to waste time on phone calls. So I agree. And yes, Francis, absolutely. I think that that we need to have that document. I know you were going to work on putting that together. That should go out. 100% agree. for that to happen, because I do think we need to make sure that everybody is playing from the same page from this, and they all understand and have the ability to ask questions. Best practices, the best thing we can do is share what people are doing well so we can replicate it as much as we can throughout the state. At the end of the day, it just helps our staff and it helps our patients. And ultimately, that's what this group is for. So 100% agree with that. Absolutely. Any other questions around, or any other questions? All right, Liz, 2023 meeting dates.
I think Gabby's getting ready to share that right now. I know organizing times is difficult for this group. It's not the only group it's difficult for. I think the big thing is that, and if I didn't mention it already, we're planning already now, obviously, for the winter meeting, which will occur. The commission meeting is March 1st, and that's a Wednesday, but this in-person meeting again will be Thursday, February 28th, or excuse me, Tuesday, February 28th. And that is the only one in-person meeting that this group does. The rest of the meeting schedule, we've scheduled it virtual just because we know how hard it is for your time to get away. So we wanted to at least just focus on one time a year. Michelle, I think that's what you and I have discussed, because we know getting away twice a year is going to be a little bit challenging, but if we make that, if we really jam pack that one time a year that we're in person, you can all, plan for it, and then we can work out the times. But we wanted to make sure that your additional meetings were timed strategically enough that there could be work between the commission meetings, and that the work groups that are working on various things could have time to get those done in a way that we could efficiently bring things forward to the commission as needed.
Any questions from the group or comments? Yeah, we did go back to, I think originally we had 2 days in person, but it's just not always realistic. If we can just focus on one, it makes it a lot easier for everybody.
So is that in-person meeting 1 hour from 10 to 11 in Brazelton?
The committee meeting, yes, but there's a whole, our GQuip group is meeting that day. The level 3, level 4 group is meeting that day. It's really kind of our state. We're calling it more of, that's sort of our leadership focused retreat, if you will. So this committee, administrators committee meeting, yes, is the 1 hour meeting.
That makes sense. Thank you.
For Tuesday, February 28th, that meeting time is to be determined because we haven't finalized that.
Oh, the schedule. Thank you.
That time.
Sorry about that. You will have, we're still working on the final details of the Tuesday schedule based on what, in fact, we have our call just this afternoon to finalize the schedule. But the other times are 10 to 11.
Yeah.
Is that what they're okay for April 24th, July 24th, and October 23rd.
Gotcha. Thanks for that clarification.
Yeah, sure. No problem. Sorry about that.
All right. Any other new business that anybody would like to add or bring up?
And Michelle, that the attendance is on the performance-based pay criteria, as well, the in-person as well as the virtual attendance at 75%, just because we need to bring this group together for in addition to the trauma medical director and the other meetings. So can we I think formally, could somebody make a motion on this so we can sort of pass this, and that way we can get invites on your calendars and block that time.
Motion.
Second.
All right, thank you all very much. So just in summary of today, fast meeting, which is what I know all of us prefer. I'll work with Francis and Amy on the throughput best practices. I'll work with Lori to be able to pull together, all three of us will work with Lori to be able to pull together a couple of different training sessions on GCC and what that would look like and some education. And we will also send out a list of who is your person at your organization. It might be somebody who's still there and maybe somebody that's left. We've seen both things happen. Maybe you, to be able to update this. So more to come on that. Would like to have a 12/1 go live, if at all possible, before the busy sixth season, which is already upon us, is starting to get ugly. So is there anything else that anybody would like to share?
Hi, good afternoon, everybody. Chris Ruiz from Doctors Hospital.
Yeah, hi, Chris.
I'd just like to introduce Brad Griffin. He's the new Chief Operating Officer to Doctors. He's been very involved with our trauma process since he's come on board. I'd just like to introduce him today.
Great. Welcome, Brad. Look forward to meeting you in person in a few months.
Thank you for having me. Glad to be here.
So we'll make sure that we have your correct contact information for our emails moving forward. And again, if there's something that is pertinent to you all, remember we are a system, but every hospital has a little nuances. And so if there's something that you really need from this group or would like for this group to tackle, please feel free to bring it forward. Either shoot me an email or shoot one of the work group folks an email, but whatever we can do to help support the system, and that's what we're here for. So thank you all. I believe that is it for today. That was, I believe, all we had. So thank you all very much. Hopefully got a few minutes back in your day. Hopefully everyone has a great Monday.
Thanks, everyone. Thanks, Michelle.